Thank you so much for coming. I did not expect all of you. We thought it like literally to be 10 people. So super thankful you guys came. Because it did take us a while to make, and we're in fourth year, so it was very nice of you. And sorry this room is so hot as well. So we decided to split it up. Darren and I did a half each, and I started with environmental stuff. So, talking about air and soil. So it's quite hard to know what to put in, but I've put the main definitions. So we have convection as an upward moving air column that's less warm and dense, and then the downward sinking of air that's cooler and more dense. So this thing called temperature inversion happens when there's no clouds and the air is really still. The ground's really cool, and it's cooler than the above air, so it stays down there, which means that there's more emissions that stay, so it can be like exacerbations of COPD and stuff. In terms of ozone, so it's an irritant gas, it's odorless, and when there's less ozone, like around Australia for example, there's more UVB because less gets absorbed in the stratosphere, so then there's more non-melanoma skin cancer. So it's BCCs more than SCCs, and then melanoma, and then more cataracts as well. Yes?
Sorry, I was just wondering, are we going to get these slides? Or?
Yes.
Okay.
So pollution, the EPA monitors it, and the main culprits are so ozone's O3, SO2, and nitrous dioxide. Nitrogen dioxide, not nitrous. And then the soil, we eat a crazy amount of soil, I don't know. And it can mainly be contaminated with lead, which is a blood test you can do, cadmium, arsenic, and don't ever test the soil, the building people will do with it. This is so random, sorry.
Sorry, we'll get rid of that.
Oh, cool. Alright, so water and food. So when you disinfect water, you add chlorine and it will oxidize pathogens, and it's most effective with bacteria and then protozoas last. In terms of the pathogens that are common, it's Cryptosporidium, Giardia, Norovirus, Pseudomonas, Campylobacter, and Legionella. And Legionella is that one that goes in the water towers, and there's that classic pneumonia question. And you can do like a urinary antigen test. In terms of food poisoning, I'll just leave that up there, you guys can read it in your own time, but I'm sure you've all had it. Typically presents with nausea, vomiting, diarrhea, abdo pain, and then staph is the one there's like this question about this impending sense of doom, and that's the staph question. And that's the one that's like 2 hours after some like picnic where there's some dairy product. And all the other ones are pretty self-explanatory. Most of them are contaminated meat and stuff. In terms of genetically modified food, so it's where you try to improve the characteristics, and there's a question about labeling. So you don't have to label it if it's highly refined, such as sugar and oil. If it aids processing, so like if they add something and it will just process it, like amylase. If it's no more than 1 in 1,000, if like the place sells food for immediate consumption, and if there's no intent to use genetically modified foods, but there's like less than 1% in the actual food. So that's when you don't have to mark it as GM. Sorry, slide. Cool, okay, so major natural events. I'm not sure how relevant this is. So earthquakes is a focus that's deep in the mantle, and then the epicenter is the point like on the Earth's surface, which is above the focus, and they cause tsunamis. Volcanoes is mainly burns and inhalation injuries. Cyclones, mostly drowning. Fires, they can increase like pulmonary disease like COPD. You can get lots of PTSD and low water quality afterwards. For the explosions, you get this sort of blast wave, and then there's a rise and fall in pressure, and that's like faster than the speed of sound or something, and that can cause like organ lacerations. And then there's like a wind that follows that, and that can cause lots of burns, and you can get like thrown against things and have traumatic amputation, which is quite crazy. In terms of outcomes, it's quite self-explanatory, I guess. So just remember your psychological trauma and things as well. Alright, so obviously our environments can be dangerous too. So in terms of kids, there's actually a lot of accidents that happen. So you'll learn this all next year, but when kids are 6 to 9 months old, they start to sit and crawl. So that's no sharp corners on your tables and things. 12 months, they'll start to stand and walk, and they can pull drinks off benches. So I've seen lots of kids in ED which have like lots of burns going down themselves because they've pulled stuff off, like a coffee cup or something. When they're 24 months, like they go outside and do lots of things, they get sunburnt and they fall. And then 2 to 4-year-olds, they'll like run in front of the road and things, and they'll start to like look inside cupboards and things and can drink chemicals and liquids and stuff. So common things are falls, like all this stuff. No nuts to people under 4. Lots of batteries that can get swallowed. And obviously prevention is supervision. In terms of the middle-aged population, sorry. So it's mainly ladder injuries, so all the stable-based stuff that you learn, and assault, so domestic violence prevention and like alcohol things. And then in the elderly population, there's lots of them still in the workforce, and there's obviously increased cognitive impairment, and lots of medications. Their sensory things are starting to decline. They've got lots of MSK conditions which can predispose them to falling and things. So that's 75% of hospitalizations in that population. So you can prevent that by exercise, vitamin D, less medications, an OT review which can like get them to put like hand rails and stuff in their houses, optimize their vision and podiatry, like with type 2 diabetes they can help the like sensation in their feet and stuff. In terms of poisoning, like they can take the wrong medication or like misread the bottles and stuff. So occupational med, what we really came for. Alright, just a quick question. So I'll give you a second to have a look. So what do you guys reckon the first one is? Just yell it out. Yep. The second one? Exposure. And the third one is risk. Cool. So in terms of the work history, so always ask occupation. It's more relevant actually in real life than in your OSCEs. I doubt you'll get an occupational med OSCE, but please don't shoot me if there is. So obviously good work is good for mental health and physical health. Gives you like productiveness in society, gives you money obviously and social interaction. If you're not employed, you can have anxiety and gloom, and it's often a cause of depression and sort of adjustment disorders and stuff. So we want a quick return to work. So it's therapeutic and it minimises long-term absence and harmful things, and it improves your quality of life. This is just what I wrote before. So the hazard is the one on the mDEA sheets, and then the risk takes into account the severity. So there's lots of different types of hazards, which is a potential for harm. I'll just go through them all. But I don't go through ergonomics, so that's things like heavy lifting and all those things, and psychosocial sort of, I think Darren goes through that later. So physical. Okay, so firstly a question. It's a bad question, I'm sorry. So I'll just explain it. So this is noise-induced hearing loss. If it was age-induced hearing loss, it would be just like a general decline. It wouldn't have that tick up at the end. So presbycusis is age-related, and that would just all be down, like in high-frequency hearing loss. And this is actually like a, it's got two, so this is like normal with the solid line in left and right ear, and then this is noise-related hearing loss, noise-induced hearing loss, sorry. And then it's measured in decibels, which is like a logarithmic scale, and that's like how loud it is, and then the frequency at the top, so high frequencies here. And that's like your consonants and stuff. And interestingly, like hammering is worse than whirring because it's like an impact noise as well, which can like impair your ossicles. And if someone had this in real life, they would have trouble like at parties and social events because they can't hear through background noise because of your lack of external hair cells. So that's important to know for next year too. Okay, physical hazards. So there's lots. Vibration can cause like sort of like a Raynaud's phenomenon. It can also like shear your tissues and cause edema, which can give you sort of carpal tunnel. And then also when you're, say you're like on the back of a truck and it's got really bad suspension, it can cause a lot of low back pain as well. Radiation, so this is in order of the electromagnetic spectrum thing. So you've got infrared as like low, and that's just heat. Then you've got visible light, so one of them's called lasers. And then you can't use them in rain or fog. There's always a question because it can scatter and like injure people. Then you've got like the ultraviolet, so that's can cause things like photokeratitis, which is essentially sunburn of your eyes, your cornea, and then sunburn as well, obviously. And then your X-rays and your gamma rays and things are all ionizing. So electrical, You've got your AC, which is like a domestic current, and that can cause like tetany and sweating. And that's what they use, like police to have like tasers. And it can also cause VF. And the DC current is like lightning, and that can cause coagulation and necrosis. And I like to think of it as like a diathermy. Like, have you ever seen like them diathermy stuff? Like, it just causes everything to coagulate. And then it can also cause asystole, which is why they like shock you if you have an AMI. Okay, so heat. So it's gained by muscles, lost by sweat. Darren talks about HAZCHEMs later, fire. And then if your body temperature is underneath 35 degrees, you'll get like irrational, you might hallucinate. And under 30, you'll get confused and you might go into BF. Important eye stuff. If you have a corneal foreign body, like if someone says, oh, like I felt something go into my eye and you can't see anything, like if you like turn out their eyelid and you can't see anything, it's really important to get an x-ray because it's really damaging. And like a penetrative eye injury is like the worst. Photokeratitis is essentially like your sunburn, so it can be really painful. They give topical anesthetic drops. Caustic liquid splash is like the classic in the chem labs, is like those eye wash things. And the bends, that's like if you're diving and you come up too quickly, you get all this blood, these bubbles in your blood, so it can cause like aseptic necrosis of your long bones, which is important to know. And then you have to go to like the Alfred and sit in the hyperbaric chamber.
So do you reckon I could jump in for a
Yeah,
sec?
so-
One thing about this particular graph, I think at some point, whether it was an Oscar or a question, there's also a sort of variation where they overlay some like sort of square brackets, and I think that was talking about the conductive, they basically, these would be playing the sounds to the person and having them register when they can hear them, but they also do them when they play them sort of through vibration as like conductive hearing. Oh. And so that would, and so you could overlay that, and generally that would be, it would be still affected if you've got this sort of this sensory neural hearing damage, but then if you've got like a, what's the non-sensory neural, the conductive hearing loss, like blocked with wax or whatever, that will be normal because the vibrations are still getting your hair cells in your ears normally, but the ones of the sound will have some problems and signs of hearing loss.
Cool. Alright, chemical. These are, so they usually cause damage when you inhale them. And they're worse obviously in confined spaces. So asphyxiation is where your oxygen gets displaced by something else with hemoglobin. So it causes irreversible brain damage like carbon monoxide. Narcosis is like nitrous oxide and things they're using kids when they have procedures, and maybe you at the dentist. And that's like glue and stuff as well. So it causes you to feel lightheaded and euphoric. And irritation, so that's things like you inhale it and it'll react with like your mucosa, and then it will cause inflammation, such as sulfur dioxide, ammonia, formaldehyde and stuff. Okay, biological hazards. So I just so you've got all these zoonoses, so from an animal to a man. So you've got rabies, Q fever, which is the classic abattoir question. Brucellosis, leptospirosis, that's like lots of sewers and things. Anthrax, and then you've got obviously human to human, which you know more than me about, so Hep B and HIV and things. And then you've got indirect things, so you can get stuff off surfaces and through food and water and vectors like mosquitoes and stuff. So obviously to prevent, you would do immunizations, hygiene, and PPE, including your condoms for HIV and stuff. In terms of plants, they can poison you, sting you, you can get allergies from them, especially there's like a aspergillus question with a farmer, because they get like moldy hay, and also contact dermatitis. And then animals can bite you and envenom you. Okay, so work-related disease. So work-related doesn't equal occupational. Occupational disease has a strong causal link, such as asbestosis in miners, and they'll definitely get compensation, but work-related, it has like, it means that your disease has been worsened by your work. And so it's things like worsening musculoskeletal diseases and noise-induced hearing loss. And like, if you're a policeman or something really distressing at work, it could like trigger your PTSD or something. In terms of other cancers, so we've got mesothelioma and bronchogenic carcinoma by asbestos. lung cancer is just silica, it's a paint or smoky environment. Bladder cancers like your dyes, working with tar and paint as well. Myeloid leukemia was benzene, and ENT cancers is hardwood dust. And there's lots of respiratory disease, so the main occupations are your bakers, animal workers working with foam or detergent. And so there's high molecular weight stuff like flour, and low molecular weight stuff like foam and dust, which is usually like volatile. And if your work caused your asthma, wait, hang on. Yes, so there's like so there's like work-induced asthma, and that's something that you need to leave your job for because you've been sensitized to something at work, so you can't keep working there. But if it's work exacerbated, then you can do things like reducing your exposure, wearing masks and things. And pneumoconiosis is like silicosis. In terms of skin disease, so you've got contact dermatitis, and 75% is irritant, and that's something that you can keep your job for as well. So it's things like hairdressers, they can wear gloves when they're handling chemicals and things. But allergic is the one where you can get like you need to do patch testing to verify, and then you have to probably leave because you're allergic to that thing. And then you've also got contact urticaria, that's like latex allergies and seafood, which is not really occupational, I guess. Alright, fitness to work. So you're essentially assessing whether your patient has physical and mental capacity for the inherent requirements of the job. So after that, you have to sort of figure that out and see, there can either be 3 outcomes. They either meet it, they meet it with modifications or restrictions, or they do not due to so-and-so. And work can actually be detrimental to the health as well. Not all work is good for everyone. So you might do this when you start a new job, or some professions like pilots have medical assessments you need to do. And also they'll have like lead and asbestos, and they have to do like yearly health assessments for that. And obviously you have to be careful with people who are pregnant. All the travellers need to do your travel medicine stuff, like look up CDC and get all your shots and stuff. And then safety critical workers, so that's like jobs who affect other people, like pilots and train drivers and police. Fitness to drive, there's a whole huge document you can read, but essentially it's 6 on 12 usually. But if you have to make sure that they're not a commercial driver, because they have tougher restrictions on that. So you don't.
Alright, so I cover the later modules, and the first thing I cover is workers' compensation. So I'm Darren, thank you all for coming, and thanks all for staying as well, because it is quite warm in here. But yeah, workers' compensation. So what's important is that it's run by, the government oversees it, and they employ WorkSafe, and then they oversee WorkCover. So there are often questions where you need to differentiate the 3 levels. So the government doesn't directly do anything with WorkCover, but they employ WorkSafe, which is a private organisation, to do so. And then WorkCover is made up of a lot of insurance companies, basically. So businesses that employ workers must have WorkCover insurance, or they can get fined. And this is because small businesses might not have enough to, fund out-of-pocket costs for compensation if something did happen. And if work is a significant contributing factor to injury or illness, then employees are covered, which is basically what Lauren just said. In terms of a bit of nitty-gritty, employers must pay for 10 days off work and up to $721. So after that, the rest is covered by WorkCover. So sometimes it can be a bit messy, so WorkSafe agents need to get involved, and they might decide that it needs to go to court or need further independent medical examinations. So in terms of some stats, the median time lost for serious claims is 5.5 weeks, with about $7,000 being paid out. And if you compare that to what employers are actually paying, it's quite a significant amount. So most of the claims are for MSK issues, with men being affected slightly more than women. And it's important to know that labourers, machinery operators or drivers, and community and personal service providers are the people who get involved with workers' compensation the most, and these industries are agriculture, forestry, fishing, manufacturing and construction. So basically the really hands-on people, or the people who are getting involved with people who might be risky. So I thought it would be reasonable to get a returning to work OSCE. Apparently Lauren didn't think so, but if you read this STEM, I'll give you like 30 seconds to read through it and try and think of what you would write in an OSCE, what you would prepare and how you would answer the questions. Yeah. So I was in SAIL last year and they did practice OSCEs for us, and this is similar to one that we got there. And it was a curveball, so not many people do revise OCMed with the intention of doing an OSCE for it, but I think it is a lot of common sense. And if you take a breath and just use a bit of common sense, then you should be able to get a lot of the marks. So just the basic areas are, what can this person do? What do they actually do for work? How do they feel about returning to work? And then from the employer perspective, how does the employer feel? And then overall, is there any reason why they can't? So to go into a bit more detail, so in an occupational medicine OSCE, you always want to say, what is your job? And then they'll say something like hairdresser. And then you have to follow up with, what do you do in your job? In which case they'll be like, oh yeah, I wash people's hair. So, and then they'll have irritant contact dermatitis or something. And then you'll be like, stop washing people's hair. And then the next thing is, are there any roles which may be more appropriate, which would be, cutting people's hair instead. And then, when you want to return someone to work, you want to do it gradually. So you want to know about the time commitments and the flexibility. So you don't want to be getting them back into full-time 8 hours a day for 5 days a week. Ideally, you want to suggest, why don't you try an hour next week and see how that goes, and from there we can plan. And then other things to be wary of are if they travel, because driving is an issue, which Lauren touched on. In this case, it would be personal travel, but you still want to know how they're getting to and from work and if they can do so, and whether or not they work alone. Because if they're working alone with a bad back and then something happens to their back, they might not be able to call for help. So you want to keep that in mind as well. From the employer perspective, you want to know, the general vibes from them. Are they supportive? And then any issues that you can help mediate. And then in terms of the patient, you need to know specifically what they can do and what they can't do. In terms of what they can do, actual movements like flexion of the arm, extension of the arm, flexion of the wrist, extension of the wrist, can you grasp objects? And then from there you can say, okay, so that means because you can't grasp, you can't make fists, that means you can't grab objects, it means you can't do any work that involves lifting or carrying. So you need to start specific and then broaden out as well. And then always assessing how they feel and whether or not they'll be able to cope and what concerns they are. And then, of course, all the other aspects of a normal history apply. So there is some specific terminology that they like to, that I think it's important to be able to differentiate. And so the top four are injury, impairment, disability, which are defined as tissue pathology. Impairment is decreased function of a body part or organ. Disability is a decreased ability to perform a task, and a handicap is a decreased capacity for a role. Does anyone want to give me an example of applying all four in a situation? Keith?
Okay. Well, if someone injured their back, they had a muscle sprain.
Yeah.
The tissue pathology is just literally the muscle sprain.
Yeah.
Decreased function, you can't. Disability is you can't lift objects. Or is that impairment?
No, so impairment is the specific action. So flexion, extension, rotation.
Okay, alright. So you can't flex your spine to pick up an object.
Yeah.
Disability, you can't do the job.
Yeah. So you can't perform a task. So you can't lift objects.
Yeah. Okay. And then handicap is you can't fulfill the role.
Yeah, so you can't be a delivery man or something. So the example I had here was a medial epicondylitis. So you have weakness with wrist flexion, and therefore you can't carry objects, and therefore you can't work in construction. Okay. The other definitions that you should know are risks, which Lauren covered, but also capacity. So it's what can they do, what can they tolerate, and it's on a spectrum. The other thing is self-efficacy, and that's how they feel about getting better and their drive to get better, because that can impact, when they return to work and whether or not they'd want to. In terms of tolerance, it's sort of the endurance. So it's their ability to sustain work, and initially when people return to work, their tolerance might be low, which is why we graduate a return to work to build the tolerance back up again. In terms of a certificate of capacity, I don't think you need to know how to fill one out, but just know generally that it does contain identifying details, it does contain a diagnosis, it contains your assessment of their capacity, and that's physical, mental, and others, and it has the treatment plan and plan for timeline to return to duties. So this goes to the employer. So the patient will come to you, you give this to the patient to give to their employer. It's important that you do talk to the patients that the employer will receive confidential information that is relevant to their condition and relevant to, if there's a work cover claim relevant to that. In terms of the planned timeline for return to duties, what that is for this amount of time you can do modified duties. For this amount of time you can do modified duties plus a few more, and then this is when we think you'll be back working full time. But this link here will bring you to the document. It's just a PDF that you can fill out. It's pretty straightforward. In terms of duty of care, so this quote is probably one of the most important quotes in all of occupational medicine. An employer must, so far as is reasonably practicable, provide and maintain a working environment that is safe and without risks to health. So I'm almost certain you'll get a question on this, and it'll be like, oh yeah, what's the employer's duty of care? What's the workplace duty of care? And they'll be like, oh yeah, they must remove all hazards and all harms or something. Or then it'll be like, there is no duty of care. The duty is based on the employee, and they need to take care of themselves. But this is often an option and almost always the answer if you see this. So reasonably practicable. And how do they enact the duty of care? So there's prevention and there's reducing risk. You probably would have heard of all these: primary, secondary, tertiary prevention. You probably would have heard of the hierarchy of controls, as well as the Swiss cheese model and bow tie model, but I'll touch on them quickly. So primary prevention is addressing the risk factors. An example of this would be banning the use of lead in pipes, brakes, radiators or paint. PPE is actually a form of primary prevention as well. But I'll talk about it in the hierarchy of controls. Secondary prevention is addressing progress and looking for signs of deterioration. So in terms of a lead example, it's monitoring the blood lead levels. Tertiary prevention is treating the consequences, and that would be something like chelation therapy for when you've been exposed to lead, you've gotten the disease, and now you need to treat it. In terms of primary prevention, hierarchy of controls is one of the things that you should know, but it is something that you can also sort of common sense in exams if you don't want to memorize it. So you start with elimination. So if there's something that's a hazard, you want to get rid of it. If you can do that, then you don't need to do anything else. But sometimes if you can't do that, you substitute it. Otherwise, you try and employ engineering controls, which is basically either isolating it, putting a cover on it, or modifying it slightly so that people aren't exposed to the hazard in the same way. Other thing is administrative controls. That's changing the way people work, so maybe telling them to take regular breaks if it's in an area that's high noise or really hot. And then finally is PPE, so that's wearing the mask, wearing gloves, but I'll talk about that quickly as well. So in terms of hazard management, there's a few things that the employer needs to do or should do to keep a safe environment. One of those is maintenance of machinery and equipment, and the definition of that is to arrest or slow the decline from perfect function to cessation of function. I remember a question where they were just like, which of these is maintenance? And it'll be like, making the pipes, like replacing the pipes with new ones or something, or like cleaning the pipes. But then then there's one random line that just says like arrests or slows the decline from perfect function, and you're like, it's probably that one. And then ventilation. So there are two types of ventilation, and I think you need to be able to differentiate. One is general dilution. For example, in rooms, we open a window, which is what we've done here because it's really hot. And quite smelly. And so that's what you do for places where you can't really do local exhaust ventilation, which is where you sort of vacuum the source or put something over the source to prevent yourself from being exposed. So if everyone here would have done chem, so like the vacuum hoods where you do some of the more do some of the experiments with the more volatile substances, that would be an example of a local exhaust ventilation. If you're in a really hot room, then general dilution would be opening a window or using aircon. So there are some tests people can do for air. There are gas detecting tubes, which are usually done by a occupational medicine. I can't remember the word. Yeah, it's not done by a physician. It's one of the allied health type people. Yeah, but so you don't need to worry about that. But something you might come across are personal monitors or badges, and these sort of are the ones that detect radiation, or in the past, like the canaries in the coal mines. Those would be, examples of personal monitors. And then there are static monitors. So, for example, fire alarms. They're just left in the ceiling. Doesn't matter if anyone's there or not. If there's a fire, it'll go off. And then lastly has chem, this is all I touch on it, is that it contains 3 key details for firefighters, okay? It's the quality of the chemicals, the agents required to extinguish any fires, and whether or not evacuation is required. So PPE is the last line of primary prevention, which is what I mentioned before, and these are some examples. In terms of respirators, which you might be asked about, there are sort of 2 types of filters. One is a woolly filter, and that catches the particles to purify the air. The other is activated charcoal, and that absorbs organic vapors. And they are useless in confined spaces, so you never want to recommend it to someone who's working in like a water tank or something. And you need to consider whether it's appropriate for a person in terms of if they have a huge beard, you won't be able to form a tight seal. And if it's disposable, then you want to make sure that people aren't reusing the same mask. So in terms of reducing risk, there's the Swiss cheese model, which I'm sure you all know, and the bow tie model. I think the more relevant one is the Swiss cheese model. And so an example would be, say, in ED, where funding and resources mean that a person, there's only an intern on, there's only one nurse on, and there's a lot of patients. And then in terms of organisation culture, this intern that's on by themselves is expected to be able to treat everything on their own, and not require, not contact seniors for help, because it can be annoying to them. And then in terms of poor designs, if we have a paper-based system that doesn't really highlight errors, then if a patient comes in with like a allergy to amoxicillin, with all these errors, like a tired intern with no support on a paper-based drug chart that doesn't flag allergies, they could easily, accidentally give amoxicillin to someone with an allergy, and then the patient comes to harm. And it's not because of one person's fault, but it's because of all these things that contribute. And then you can apply that to the bow tie model as well, basically, where the threats are, they're tired, they don't have resources, and the hazard is someone comes in with an anaphylactic reaction to amoxicillin, and then the consequences are as I described. So another thing I need to talk about is stress at work. I thought this was pretty witty, but not many. No? Okay, sure. So we need to be able to define it. You need to know common stresses, and you need to know the employer's role. So work-related stress, it is physiological and emotional responses that occur when workers perceive an imbalance between their work demands and their capability or resources to meet these demands. So it's not a disease, but people do respond differently and can still have consequences on health, on the work and on the workplace. So, common things that you could think of are alcohol use disorders, cardiovascular disease, because you would have heard people be like, oh yeah, this is raising my blood pressure, and then anxiety. The other thing on the workplace is people might not want to go in, the team don't want to talk to each other, they're less productive, and then, of course, if they need to take time off, the employers need to pay compensation. So the main domains are demands of the role, the control, the support relationships, the role itself, and the the change and how that's supported. So these are some things that employers can do to address these domains, and they're mostly common sense, and you can read through them in your own time. So in terms of behaviours at work, did you guys all do I belong? So this is basically the I belong module, and it's, well, you should have all done it because you shouldn't be allowed on, right? What? Oh, okay. Well, when you're at Monash, you'll do it, and it's basically a module on, on bullying, harassment, and stalking and stuff like that. So what bullying is, it's a repetition of unreasonable behaviour that has the potential to cause harm. So it might not necessarily be harmful, but it is repetitive, it's unreasonable, and it's generally unwanted, and it's enduring over time. So it generally has to occur for more than a week. It often occurs in the setting of a power imbalance, such as like a boss talking to the people that they manage. But it doesn't include things like reasonable requests, denying promotions, or dismissal of someone for an actual reason other than like, I just don't like him. So harassment. Now before you start laughing at my pronunciation, if you Google it and you look at the phonetics and the IPA dictionary, it's actually pronounced harassment, okay? The second pronunciation is harassment. But if you if you wanna, elevate your vocabulary, then sure. But basically, it's a humiliating behaviour. It's a humiliating behaviour on the basis of a person's characteristics. So this can be gender, race, body shape, and it's not necessarily repeated, because if it is repeated, you can call it bullying. So generally, for questions regarding harassment, it'll be a one-off thing. And stalking is the constellation of behaviour where someone repeatedly inflicts unwanted intrusions or communications. It's generally one-sided, and to prevent it or to sort of manage it, the victim of the stalking must be firm in terminating the association with the stalker, because the stalker is often insensitive and feels entitled to this relationship. So something they can do is, an example would be, stop, I don't like what you're doing and I don't want you to contact me anymore. So it is quite confronting, and it's it can be very hard for someone to say that. But other things you can consider are reporting to support groups, especially when children are involved. You can get some DHS maybe, talking to superiors if it's occurring in the workplace, or if it's occurring outside of that, you can go to the police and they might refer you to the courts for a restraining order. In terms of other things that were covered at behaviours at work, intellectual disability. So just because someone has an intellectual disability doesn't immediately mean that they're unemployable and shouldn't be in the workplace. They can't be discriminated against if they can meet the inherent requirements of the job after reasonable adjustments. So someone who has a mild intellectual disability, that means that they can't process written instructions very well, but if you have a picture or two to go alongside that, then they can do their job. They should be allowed to work, and you shouldn't be discriminating against them, because putting pictures with instructions is very reasonable and will help other people in the workplace too. So other adjustments are making sure that jobs are small and learnable, having a routine, using visual aids, and an important one is optimising medical management at home. So sometimes these people will have comorbidities, or for their intellectual disability they'll need regular medications, and it's ensuring that at home the people at home are supported enough to do the medical management, and this leads on into the workplace as well. Sometimes they may have issues with social interactions, they might be a bit aggressive, and you just need to be patient and de-escalate the violence appropriately. And in the workplace, or in general in practice, if you're de-escalating violence, one thing you want to do is maintain space between you and the person who's violent, and avoid strong eye contact. So you don't want to be in range of them to throw a punch at you, and you don't want to be goading them with very strong eye contact. You want to appear calm, respectful, and self-controlled and confident, because if you show that you're weaker than them and create a power imbalance. It might make them feel like they're dominating. So you also want to be clear and direct in the language, and also clarify what they're saying if you're unsure. That's okay. So if someone says something you're not sure, just say, "I'm not quite sure what you said. Can you please say it again?" And you can be silent if you need to as well. So sometimes there might be questions where there's a violent person, and they'll say, which of these is not appropriate to do in this situation, and 4 of these will be an answer, and then the 5th one will be something like throw a chair at them or something. And the last thing is anxiety. So anxiety is characterized by chest tightness, paresthesia, carpopedal spasm. So do you guys know Trousseau's sign for hypocalcemia? That's basically carpopedal spasm, and they'll also have presyncope as well. So mass sociogenic illness is sometimes called mass hysteria, and it sort of does present with anxiety symptoms, but it occurs in a group. They all get the symptoms at the same time or in a very similar time frame. They have benign transient symptoms, and there's no organic etiology. So the history you'll get is you can identify an index case. So one person maybe smelt got a whiff of an odor in the air and thought maybe, oh no, this is carbon monoxide, I'm going to die. And then they start panicking, and they're like to all their peers, oh no, I think there's carbon monoxide in the air, that can kill us all. And then so people start being like, oh yeah, wait, now that you mention it, I think I'm developing a headache. And so that sort of spreads through the group. And it can be through conversations, it can be through seeing someone react in a certain way, it can be through hearing someone react in a certain way. And females are affected more than males. And the symptoms are of sort of anxiety symptoms, so headache, dizziness, faintness, weakness, and choking. And there can be a trigger, sort of like the smell. So giving advice, in occupational medicine, you're giving a lot of advice, and a doctor's advice is very influential. So you need to be careful of what you say and whether or not it's actually creating a beneficial effect. So one thing is lack of persuasion. When you're talking to a patient, you want to make sure that they understand what you're saying and that they believe that you care about what they care about. Because if someone comes to you with abdo pain and you think they've got appendicitis and need to go to surgery ASAP, then you don't want to be like, okay, you need to go to the hospital now, I'll call the surgeon while you're on the way, because then they'll be like, I'm still in pain, this person hasn't helped me with my pain. So you want to make sure that you're addressing what they want addressed as well as addressing what you want to address. You don't want to mislead people. This can be the case when we're breaking bad news, or we're giving good news, or we're unsure of what the news is at all. So you don't want to overstate what you're saying or provide false information, and certain words have connotations to the public, such as like cancer, HIV. We know that cancer is on a spectrum, and that it's not the end of the world for everyone who gets it. It's not the end of the world for most people who get it, actually. And then things like HIV are very treatable now, and the life expectancy is almost the same as a person who doesn't have HIV. And then you want to be careful of moralizing as well. So that's when you have an opinion and you tell it to the patient in terms of right and wrong. For example, if someone has an opinion on abortion and they tell the patients that abortions are good, everyone should get abortions, instead of saying it's my opinion based on my moral and cultural principles that abortions should be accessible to everyone. And you also want to be careful of counselling in uncertain situations. So patients who come in asking for tests or meds or certain referrals, you need to acknowledge their concerns, but you also need to do a proper and thorough history and don't let them dictate what's going on. This can happen in GP a lot, where people want antibiotics, but you say, okay, I understand you want antibiotics, but let me just ask you a few questions first, and then just go through a proper and thorough history. And before ordering a test, you need to have a working diagnosis, plan what you'll do to any positive or negative results. You should sort of know what you're expecting, because you want to be confirming your working diagnosis, and you want to be able to communicate the result to the patient and formulate a management plan from there. So when you're giving diagnoses, there are three sort of things that you need to differentiate. You need to know that a disease is a pathological change. An illness is where you have symptoms and a change in behaviour, and a syndrome is a collection of signs and symptoms from a common etiology. So examples of syndromes are like Down syndrome, or where we sort of know the etiology, but also things like Kawasaki's disease or PCOS, which we sort of know how it works, but we don't really know the etiology. And two things that they describe in OCMED are medically undefined illness. So patients will come in with symptoms such as like dizziness, headache, pain, but they'll have no identifiable pathological cause. In this case, the doctor needs to exclude serious pathology, and then you need to cease interacting with the patient in terms of from a perspective of trying to treat this medically undefined illness. This is because long term the patients can develop a power imbalance over the doctor, so they can say things like, you don't know why I have this headache. Do you think maybe I can get all these tests done? And then the doctor might, be pressured to say yes. Or, since you can't manage my pain, how about you give me some opioids or something? And so it becomes a situation where the patient might be dictating what's going on between the doctor and the patient. And then syndromes ascribed to situations. This is sort of like Gulf War syndrome. I don't know if you've heard of that, but people who sort of come from a certain place or have been exposed to a particular event, and they all present with very similar symptoms, and you're sort of not sure why. So if you try and identify you try to identify the cause and communicate it to the relevant authorities if you can, but if you can't, it's just a social thing. So normally diagnoses are medical because we want to treat, but sometimes you need to give these social diagnoses so that they can access groups, support groups and benefits like from the government. And then you want to be supportive and sustain whatever they decide to do. So this is just a general OSCE approach, similar to one that I covered, but this is Chelsea Matley's from the year above us. You can read through it in your own time. It's pretty straightforward and it's pretty much what we've covered. But, something I thought I would quickly cover is approaching the John Desmond Prize exam. So I'm not sure how many people do it, but last year everyone in SAIL did it. I thought it was good revision. We had 60 questions in 60 minutes, but you guys have 70 questions in 60 minutes, so you need to be more efficient with your time. I found that I used all the time, and some people didn't finish with the time given, so you need to be speedy. One thing that I thought might be helpful is that you don't need to know everything, you just need to know where to find it. So John Desmond is open book, so you can Alt-Tab, you can Control F, and it's just knowing where to Control F and what to Control F. Because sometimes they'll be like, instead of using reasonably practicable, they'll be like, they do something that's reasonable and able to be implemented in the workplace, So you need to know that, if I'm looking through guidelines or something, I want to be looking up reasonably practicable. So I don't know if you guys know of the 300 points revision document on Moodle. That is a very good one to have handy to Control F. I didn't know about it until a previous John Desmond Prize winner told me about it as well. So I've got the link there. Another thing is the road rules. So the Vic Roads document, that's linked there as well. So there'll often be questions about, when can this person go back to driving after having a seizure, or this person has diabetes, what do they need to have ready to be able to drive? You can have your notes, have revision slides, have WorkSafe, and then Moodle modules I thought were very difficult and time-consuming to Control F, because you need to remember which module it is, and then within the module there are multiple files, and then you need to find the file. And then if you have them all up, you have like 50 files up on your desktop, so you can't. So ideally you have an understanding before, and you don't need to get there. So I have some practice questions. It's only 8 of them. I wrote them myself, and all characters in Sims are fictional, and any resemblance is coincidental, okay? So just call out the answer. Yeah, it's a hazard. Because he's lying in the middle of the road and he has like things that can spill and can cause people to trip. So this is an exposure. So I tried to get it across that, you know, there was an exposure, but there doesn't necessarily have to be a negative outcome or a negative consequence to an exposure. It just has to be something that you've come across. So that's why, like, in the hospital, they suggest you do risk mans if you almost slip on something, because almost slipping on something is that close to having an unwanted outcome. Yeah, that's right. So basically, returning to work earlier is good in every way, so just look for the thing that's bad. Does someone want to yell it out? Chemical? And what's the chemical? Yeah, that's right. So it was a chemical thing, and it was carbon monoxide. So fires indoors, cars in enclosed spaces, or faulty gas heaters can all have carbon monoxide. Does anyone have an answer? Sorry? Did someone say B? It's C. So basically, I think it's important to know that crocodilite, also known as blue asbestos fibres, are the ones that are associated most with lung cancer or malignant mesothelioma. However, the other asbestos fibres, which there are like 5 of them, are more common and do have an increased risk of lung cancer as well. And it's more common to find people who have had lung cancer due to that, because it's a more common thing in the population. But crocodilite is highly associated with cancer. It's got the highest rate. Someone want to give me an answer? Can someone yell it out loudly? D? Yeah, audiometry, because it's monitoring. Earmuffs, replacing the loud machinery, and the regular brakes are all primary prevention. Hearing aids is tertiary. So what do people think? I heard C and E. So it's E because if we're doing C, it's still making the same noise, so they're still being exposed to the same hazard. It's just that the machines are better. So from an employer perspective, that's good, but from an occupational medicine perspective, that means nothing. So which of the would be most effective? If you remember the hierarchy of controls, engineering controls are above administrative. So engineering would be isolating the noise, administrative would be giving them breaks from the noise. No, so this didn't actually happen. So what do you guys think it is?
Is it reasonable?
Yeah, I thought it was reasonable. So basically, there are situations when businesses and employers will have to let people go and fire them. If there's no indication or evidence otherwise that, you know, they are constantly tormenting their staff or picking on someone in particular, they do have to make tough decisions sometimes, and you know, they just have to let people go. So firing someone or dismissal, as was mentioned before, isn't always, you know, something that's bullying or harassment. And I remember questions where they do talk about someone being fired or someone having arguments with their manager because they're giving them sort of demands that they don't want to do or they think are unrealistic. It's important to look at the whole stem and see if there's a pattern of behaviour and see if it's reasonable or not, because you need to look from both perspectives. Because even while you want to put your patient first, you know, this, like, treating them on a pedestal might be negative for them in the future. Actually, no, I've got another question. Sorry, 9 questions, guys. Mm-hmm. So what are people thinking? So I think I heard all the letters, and the answer I have is A. So when people think of inversions, they normally think of the bottom 2 layers, which is the cold air, and then the warm air above it, which traps it. So normally heat is produced at the ground level and rises, but sometimes, you know, in inversions, the ground level air is cold and full of pollutants, and because it's colder than the air that's slightly above it, and therefore it doesn't want to rise. Therefore it stays on the ground because it's colder than the air above it, and then the warm air that's above it is sort of trying to rise as well, but it's blanketed by cold air above that, because if you go all the way out into space, it's cold air. So on the top is cold air, and then there's warm air under that, and then there's cold air trying to. Yeah. Anyway, so the key thing is normally warm air is made on the ground and rises up. In an inversion, there's somehow cold air on the ground which doesn't rise up. Okay?
I feel like it might be B.
No. If you can just Google a diagram of temperature inversion.
Thanks, guys.